Colorectal cancers account for a global incidence of 10%, being the third most common cancer worldwide. It ranks second in males and third in females. It accounts for 9.4% of the cancer deaths worldwide. It is a heterogeneous disease with distinct molecular signatures, pathological features, and natural history. The carcinogenesis of colorectal cancer progresses through accumulation of genetic and epigenetic changes involving oncogenes, tumor suppressor genes, and mismatch repair genes. 70 to 80%, 70 to 80% of the colorectal cancers are sporadic, 20 to 25% although have a hereditary component. Colorectal cancers develop within benign precursor polyps. The activating mutations being in the gatekeeper genes, which constitutively activate WNT signaling pathway. This results in epithelial overgrowth, and further additional mutation brings about invasion and metastasis. Hyperplastic polyps confer the lowest risk of carcinogenesis. Most commonly, cancers arise from adenomas, the earliest change being aberrant crypt focus. Sessile adenomas do account for carcinogenesis in some patients which have a serrated histology, characteristic nuclear morphology, and little or no dysplasia. Now we have the classical adenoma carcinoma sequence, which was given by Vogelstein et al. In the year 1988. In this, the gatekeeper mutation starts with the APC gene at the locus 5q21, which follows the Knudsen two-hit hypothesis. The first hit may be acquired or inherited. This later on, due to inactivation of the normal allele, which is the second hit, the mucosa comes at risk for further mutations which may come across. Proto-oncogene mutation acquisition, the KRAS mutation at 12p12 locus brings about the adenoma change, and later due to loss of heterozygosity at 18q21 with the SMAD2, SMAD4 and DCC and p53 loss, there occurs invasion and hence carcinogenesis. Although this is the most common pathway, apart from this, there is a pathway which involves the mismatch repair genes, predominant genes being the MLH1, MSH2, MSH6, PMS2, and PMS1. Now, these mutations may be either germline, as in HNPCC, or somatic. Now, this results in insertion or deletion of multiple repetitive sequences of DNA, and this results in error in replication. Now further, due to alteration in the second allele, there results microsatellite instability or the mutator phenotype. The resultant morphological picture is that of a sessile serrated adenoma, and due to further accumulation of mutations like TGF beta, BAX and BRAF, there occurs invasion and hence carcinoma. Now, 84% of the colorectal cancers progress along the normal pathway, having chromosomal instability, while 13% of the cases have microsatellite instability, which may either be DMMR or maybe CIMP, which is the CpG island methylation phenotype. 3%, although cancers have mutations in exonuclease domain of proofreading DNA replicating enzyme pol or pol D1, the TCGA, which is the Cancer Genome Atlas Integrated Classification in 2012, categorized them into two groups: non-hypermutated, having the CIN type with high DNA somatic copy number alterations, rate being less than 8 per MB and having WNT pathway deregulation. The other group being the hypermutated group, having two subdivisions: the MSI high with DMMR or CIMP, low somatic copy number alterations, BRAF V600E mutations being seen in CIMP type, and rate of 12 to 40 per MB. The second subtype under it is the POL1, POL-D1. These are actually the ultra mutated variant with rates more than 40 MB. Now, coming to the basic molecular pathways involved in colorectal carcinogenesis, WNT pathway is the prime pathway which is actually involved. Now, over here, as we can see, the WNT glycoproteins bind with the frizzled LRP56 co-receptor complex, which serves to inhibit the destruction complex formed by axin and APC gene product. Now, this destruction complex actually serves to subject the beta-catenin to proteasomal degradation, and hence its inhibition brings about stabilization of the beta-catenin, which then translocates to the nucleus and transcripts and results in transcription of target genes like CMYC and cyclin D1, which fosters cell growth. Now, this pathway is co-regulated by many other mediators such as R-spondin, which binds to its receptor LGR56 and inhibits the transmembrane ubiquitin ligase RNF43. This ligase actually degrades the frizzled molecules. Now, the inhibitor of this ligase results in increased density of these frizzled molecules, which increases the susceptibility of the cell to WNT pathway. Now, another one pathway which is of importance is the receptor tyrosine kinase and the mitogen activated protein kinase pathway. The most important receptor being the endothelial growth factor receptor. In this pathway, when the ligand binds to the receptor dimerization occurs, and later the internal subunit of the receptor, which houses the PI3K, undergoes numerous changes. It, in one hand, activates a cascade of molecules like RAS, RAF, MEK, and mitogen activated protein kinase, which results in cell cycle progression and proliferation, while on the other hand, it gets converted to PIP3, which recruits AKT to the cell membrane and activates the mTOR pathway, which is responsible for protein synthesis and cell growth. The PTEN gene inhibits the PIP3 complex and hence inhibits the mTOR. So these are the common somatic mutations which are seen in colorectal cancers. Among the oncogenes, it is KRAS in 35 to 40%, BRAF in 7 to 15%, while the tumor suppressor genes, APC accounts for 85% of the colorectal cancers, and P53 mutation is seen in up to 50% cases. Molecular classification of colorectal cancers. Colorectal cancer is one of the earliest molecularly characterized solid tumor. Several classifications have been given based on gene expression profile of the tumor. However, there are differences in terms of sample processing, analysis, algorithm, population differences, and proposed subtypes. And these classifications not only encompass the tumor cells, but also the immune and stromal components of the cancer. Now, coming to the various classifications, the first one being one by Schlicker et al. In the year 2012, they gave two broad subtypes, type 1 mesenchymal and type 2 epithelial, which were further subcharacterized as shown in this table. Among these, the important one being the subtype 1.2, which has upregulation of immune system related pathways and was found to be highly enriched for MSI high. These were found to be later susceptible to inhibition of SRC and PI3K pathway. The second classification was given by Budinska et al. In the year 2012, in which there was 5 subtypes. Type A being the surface crypt-like with KRAS mutation, type B with lower crypt-like with WNT activation, type C CIMP high-like with MSI and BRAF mutation, fourth being the mesenchymal with EMT and stromal upregulation, and type E being the mixed type. Subtype C and D among these had the worst overall survival. The third classification by Mariza et al. In 2013 was basically based on driver mutations like KRAS, BRAF, P53, presence of CIN, presence of CIMP. Now, these were divided into 6 groups. Among them, subtypes C1, C6, and C5 and C6 all had chromosomal instability, while C2 had defective MMR and C3 had KRAS upregulation. And C4 and C6 was found to be associated with shortest relapse-free survival. The classification by Sadanandam et al. In the year 2013 characterized colorectal cancers into 5 subtypes: inflammatory, goblet, enterocyte, transit amplifying, and stem-like. Among these, good prognosis was seen with goblet and transit amplifying subtypes. The transit amplifying was further characterized on the basis of sensitivity to cetuximab. The stem cell variant, however, had mesenchymal features which had a worse prognosis and was found to benefit from adjuvant chemotherapy. Mostly, it was from the maximum response was noted with FOLFIRI. The classification given by D'Souza et al. In 2013 subtyped colorectal cancers into CCS 1 to 3. The subtype 1 with epithelial characteristics, CIN, mainly being left-sided KRAS and P53 mutation. Type 2 mainly being right-sided with DMMR, MSI high type. Type 3 being mesenchymal with BRAF and KRAS mutation. And also it had associated matrix remodeling and EMT gene upregulation and was associated with poor prognosis. The third subtype was found to have resistance to anti-EGFR directed therapies. Now, another one classification which came up was in the year 2014 by Ropeman et al. And in this, there were three subtypes. The first one was DMMR epithelial, which was hypermutated, having a good prognosis with BRAF mutation. Second being the proliferative epithelial with BRAF wild type variant. It benefited most from adjuvant chemotherapy. While the third subtype was mesenchymal with a similar EMT presence and was having a poor baseline prognosis. This classification, however, was focused primarily on stages 2 and 3 colorectal cancers, while the others had taken into consideration all the colorectal cancers. Now, the colorectal cancer research community formed an international consortium by the Colorectal Cancer Subtyping Consortium in the year 2015 to nullify these inconsistencies existing in the subclassification system. They analyzed transcriptomic-based classification, including around 4,151 patients, and gave 4 biologically distinct consensus molecular subtypes by the name of CMS. They also mentioned that there were some tumors which fell into mixed, which had mixed features and and were subclassified as the fifth subgroup with 13% patients, and they were thought to represent transition phenotype or intratumoral heterogeneity. Coming to the 4 major subtypes, it is CMS1 being MSI immune, CMS which was 14%, CMS2 canonical with 37%, CMS3 metabolic with 13%, and CMS4 mesenchymal with 23% of the colorectal cancers. Now, coming to the various salient features of all these subtypes, CMS1 was found to be located predominantly in proximal colon, while CMS2 and CMS4 were located in the distal colon. Higher grade tumors were associated with CMS1, while advanced stages tumors were predominantly CMS4. Females were more affected compared to males in CMS1. Now, coming to the characteristic genetic signature, CMS1 had MSI high or the DMMR variant and had hypermutation to it, while chromosomal instability was seen in the remaining 3 subtypes. The somatic copy number alteration was noted as high in CMS2 and 4 variants. Among the epigenomic features, high methylation, that is the CpG island methylator phenotype, was noted with CMS1, while CMS3 had intermediate methylation, the rest two having low methylation. Now, when we come across the molecular features among the various CMS subtypes, receptor tyrosine kinase and mitogen activated protein kinase pathway was upregulated in CMS1 and 3, while WNT and MYC pathway was found to be upregulated in CMS subtype 2. BRAF mutation was found to be present in CMS1, while in CMS3, KRAS mutation was characteristically noted. Among the other genes which were upregulated in CMS2 include EGFR, ERBB2, IGF2, IRS2, HNF, and HNF4 alpha. However, EMT genes, in which included TGF beta and integrin, were upregulated in CMS4. Now, coming to the characteristic which was seen in CMS1, they were characterized by immune infiltration and upregulation of immune evasion pathways. Metabolic deregulation was characteristically noted with CMS3, while angiogenesis and stromal infiltration were the hallmark for CMS4. Now, this is a pictorial representation comparing the previous TCGA classification with the current CMS subtypes. In here, as we can note, the hypermutated variant all came under the CMS1, which is the MSI immune, and the chromosomal instability, which accounted for 84% of the patients, fell into either of the 3 categories of CMS2, 3, and 4. Now, how do we actually characterize the colorectal cancer into the various subtypes? This can actually be done now using the colotype, which is basically a 40 gene signature. The genes have been mentioned in the tabular form below. These genes can be, this signature can be done based on both frozen as well as formalin fixed paraffin embedded tissue. And the technique used is whole genome analysis or targeted RNA sequencing. Coming to the clinical utility of molecular classification, the CMS taxonomy provides insight into tumor biology. Its clinical implication depends on the prognostic value, as in estimating survival in terms of overall survival and relapse-free survival, while the predictive value as in terms of decision-making for the tumor. Now, as we can see, first of all, let's discuss about the application in localized setup. The CMS is prognostic. How can we say so? It's basically by the Kaplan-Meier survival analysis curves. The top row represents curves for overall survival and relapse-free survival. As we can see, the green line denotes the CMS4, and CMS4 was found to have worse overall survival as well as relapse-free survival, which may actually be explained due to the invasive and mesenchymal properties of CMS4. Now, coming to the survival after relapse curve, CMS1 was found to be associated with the worst survival after relapse, and this may be due to the presence of microsatellite instability along with the presence of BRAF mutation, which is a very strong prognostic factor. There are even other features which can give prognostic value, like the tumor microenvironment features like chemokine-like factor in CMS1, which accounts for lymphocyte infiltration, which is a favorable factor, while the unfavorable factors include Kruppel-like factor and GREM1 in CMS4, accounting for tissue remodeling and cancer-associated fibroblast respectively. Coming to the predictive value of the molecular classification, as we can see from this forest plot, adjuvant chemotherapy was found to be associated with improved overall survival for stages 2 and 3 colorectal cancers in CMS 2 and 3 variants, hazard ratio ranging from 0.16 to 0.45. Also, there were studies, one of them being done by Song and et al. In the year 2016, which carried out a secondary analysis of the NSABP C07 trial and showed that the addition of oxaliplatin to 5-fluorouracil increased the relapse-free survival in stage 3 CMS type 2. However, this was not noted with the stage 2 CMS. Also, another study was done by Po Giel Kale et al. In the year 2019, in which they sought to associate the molecular signatures with oxaliplatin benefit in the Mosaic trial. And they found that there was no additional benefit noted with the addition of Folfox to addition of oxaliplatin to 5-fluorouracil in CMS4. Now, this is coming to Connection 2 trial, which was actually registered in the year 2019. It is a actively ongoing trial. It aims to give predictive value for CMS in the neoadjuvant setup. The sample size was established to be 262. The candidates who were taken up who have been proposed to be included in the trial include resectable, microsatellite stable clinical T3, T4 disease. Nodes were not taken into account in this trial, but being definitely non-metastatic. The study design being 2 cycles of neoadjuvant chemotherapy followed by surgery, followed by 2 cycles of adjuvant chemotherapy. The chemotherapy being planned is Kipox. The endpoints were defined as primarily being pathological tumor response, while overall survival and relapse-free survival were defined as the secondary endpoints. Now, coming along to application in the metastatic setup, prognostic value is also holds true in the metastatic setup for colorectal cancer molecular classification. As we can see from this representation, the overall survival was found to be best for CMS2, which is indicated by the blue bar, which is 36.4 months, while it was worse for CMS1 by the yellow bar, 11.2 months. Progression-free survival was found to be worst for CMS1. This data has been taken up from a meta-analysis given in the year 2021. Now coming to the predictive value of molecular classification in metastatic colorectal cancers, as we can see again from the table below, irinotecan backbone has been found to be associated with increased progression-free survival as well as overall survival in the CMS4 variant, which is represented by the green bar. 2 studies which I would like to quote are the tricolor trial conducted in the year 2020 by Yuki et al., in which the better response was noted with S1 in addition to irinotecan and bevacizumab, uh, um, which was better in comparison to Folfox or Kepox in addition to bevacizumab. Another study by Borelli et al. In 2020, called as the TRIBE2 study, established better response with the addition of irinotecan to Folfox and bevacizumab. There is another study by Moe et al. In 2018 in which molecular analysis of the AGI-TG MAX trial was done. They showed that overall survival and progression-free survival was increased with the addition of bevacizumab to capecitabine plus minus mitomycin in CMS2 and 3 variants. However, another trial carried out by Del Rio et al. In 2017 did another comparison in which bevacizumab addition to FOLFIRI was noted to have better response in CMS4, as we can see over here. Coming to another one trial, which was conducted by Stinzing et al. In the year 2019, in which they carried out, they basically tried to assess the colorectal cancer molecular subtypes and analyze the efficacy of the chemotherapeutic agents among the patients included in the FIRE03 trial. In this, the patients who were included were metastatic colorectal cancer patients with ECOG 0 to 2 having KRAS and RAS wild type mutation. These were randomized into two arms, one with FOLFIRI with cetuximab, the other with the bevacizumab arm. Superior objective response was noted with FOLFIRI in the cetuximab arm, p-value being 0.0029. However, there was no significant difference in overall survival among the groups. They suggested the CMS to be both prognostic as well as predictive. Predictive in terms of better response in CMS4, prognostic in terms of best survival for CMS2 and worst survival for CMS1. I'll be the CLGB, the SWOG 80405 trial, which was carried out by Lenz et al. In 2019, basically tried to analyze the addition of the response of bevacizumab or cetuximab to tried to assess their addition to FOLFOX or FOLFIRI among the various CMS types. They found that bevacizumab addition had better response in CMS1 indicated by the first bar. However, cetuximab was found to be more effective in CMS2. The study included KRAS wild-type metastatic colorectal cancer. A study conducted by Trin et al. In 2017 by the Cairo 2 study showed that cetuximab addition to CAPOX and bevacizumab increased overall survival. In KRAS wild-type CMS2 variant, survival increased from 23 to 33 months. In 2017, a meta-analysis was carried out by Arnold et al. And they included 6 randomized controlled trials. The result of this meta-analysis was they found that significant benefit was found for the addition of EGFR antibody therapy to chemotherapy among the left-sided tumors, which were CMS2, RAS, wild-type metastatic colorectal cancers, as compared to the chemotherapy alone group with or without bevacizumab. And there was found to be a better trend towards objective response with CMS2, however, not significant. They also showed that worse prognosis was seen for CMS1, which is the right-sided tumor. And according to their result, they concluded that tumor location determines the efficacy of biological therapies. Another trial by Okita A et al. In the year 2019 served to retrospectively analyze the colorectal cancer subtypes to predict response, to predict their efficacy for various chemotherapeutic agents in metastatic colorectal cancers. They showed that DNA methylation status was an independent predictive factor for determining the efficacy of the anti-EGFR therapy in RAS wild-type metastatic colorectal cancers, and this was in fact more useful than the tumor sidedness quoted by the previous meta-analysis as well as the CMS types. They also showed that topoisomerase 1 inhibitor and carboxylesterase expression was predictive of irinotecan response, and they found that their levels were higher with CMS4 and hence explains the sensitivity of CMS4 to irinotecan. Now, coming to the potential targeted therapies which may come into future use, first I would like to discuss about immunotherapy, which has actually been recommended as first line in previously treated MSI high DMMR metastatic colorectal cancers. CMS1 tumors being characterized with lymphocytic infiltrate might benefit from immunotherapy. The promising drugs include pembrolizumab and nivolumab with or without ipilimumab. The second potential targeted therapy is the angiogenesis inhibitors, which have been recommended as of now as second line agents in previously treated metastatic colorectal cancers. These inhibitors might actually benefit CMS4 variants, which have EMT expression as well as angiogenesis, as well as characteristic increased angiogenesis. The agents in point are regorafenib, which is a small molecule kinase, multi-kinase inhibitor targeting VEGFR3 and FGFR1. A retrospective analysis from the correct study, which was basically done comparing regorafenib versus placebo in chemorefractory metastatic colorectal cancers. This retrospective analysis suggested that C4, C6 subtypes, as in Meriza et al., which had EMT-related genes, had better response. So this may further suggest that CMS4 may also benefit since it has the EMT-related genes. There is a promising drug by the name of nintedanib, which blocks FGFR, PDGFR, and VEGFR receptors. A study conducted in the year 2021 has been found to be associated with increased progression-free survival in CMS4 tumors compared to placebo. To conclude, CMS classification is a robust framework for both prognostication and for predicting treatment benefit in a biology-driven, patient-centered fashion. Molecular subtypes should be considered distinct disease entities with distinct biological behavior and potentially different sensitivity to chemotherapy, targeted agents, and immunotherapy. The ultimate goal of this classification is to streamline biomarker and drug co-development, as also to recruit patients for the various clinical trials of targeted agents based on the underlying molecular makeup.